You're on call, a page comes in, sudden vision loss. Or maybe it's a patient with a red, painful eye who can't even look at the light. These aren't just textbook cases. They are diagnostic emergencies, and they demand a really sharp, systematic approach. So in this explainer, we're going to build that clinical framework, moving from symptom to anatomy to diagnosis for the key disorders of our special senses. Okay, picture this. It's 2 in the morning. The page you get is for acute, painless vision loss in one eye. The list of possibilities is huge, the stakes couldn't be any higher, and let's be honest, the anatomy is a total maze. So where do you even begin? We're going to build the framework you need to cut right through that complexity, and we're starting right now. So here's our game plan for today. We're going to kick things off with vision loss, really decoding that pathway from the eye all the way to the brain. Then we'll build a solid framework for tackling the red eye. After that, we'll dive into the crucial clues that are hiding in smell, taste, hearing, and balance. And we'll wrap it all up with a pocket guide, just the high-yield takeaways you can start using on your very next shift.
All right, first up, the patient with vision loss. Now, if there's one secret to neurology, it's this. You have to think anatomically. Every single symptom has a location. So we're going to follow the visual pathway from the very front of the eye, the cornea, all the way back to the occipital cortex, localizing the problem one step at a time.
But before we get deep into the anatomy, let's get your clinical brain warmed up. So imagine a patient comes in and says they can't see things on the sides, on both sides. They keep bumping into door frames. Just think about that pattern for a second. Where in the entire visual pathway could one single lesion cause that very specific defect? Let's take a look at the map. Okay, I know this map looks complicated, but it's your Rosetta Stone for vision loss. Seriously. Look at the visual fields up in the top left. See pattern H, that bitemporal hemianopia? That's the peripheral vision loss we were just talking about. Now just follow the lines from the temporal or outer part of each retina. See how they both cross over at that one central point labeled H? That's the optic chiasm. A single lesion right there is the classic cause. Now check out pattern K, an inferior quadrantinopia. Follow those fibers back, and you land way deep in the parietal lobe. The patient's symptom is literally a pointer on this map. So that map is perfect for figuring out problems behind the eye. But what if the problem is right in the eye itself? Before you even think about ordering an MRI, you have to remember your most powerful tool might be the one you've got in your pocket. The optimoscope lets you look directly at the retina and the optic nerve, and sometimes the answer is just right there waiting for you. And wow, what a view it is. On the left, you're looking at hypertensive retinopathy. Chronic high blood pressure just wrecks those tiny retinal arteries. See those flame hemorrhages? Those are little bleeds. And the fluffy cotton wool spots? Those are actually microinfarcts, tiny strokes happening right on the retina. Now look to the right. That's proliferative diabetic retinopathy. High blood sugar starves the retina of oxygen, so it panics and tries to grow new blood vessels. That's neovascularization. But the problem is, these new vessels are weak and leaky, and they can lead to catastrophic vision loss. Two huge systemic diseases, two totally different patterns of damage you can see with your own eyes. Now for 3 diagnoses you absolutely cannot miss, where the patient's story is everything. For a retinal detachment, you'll hear about floaters and flashing lights. The curtain falling over their vision, that's the shadow of the detached retina itself. For glaucoma, the increased pressure slowly kills the optic nerve fibers from the outside in, which causes that sneaky, gradual loss of peripheral vision. And a cataract, well, that's just a clouding of the lens. It's like the patient is trying to look through a foggy window all the time. Okay, let's switch gears. We're moving from loss of vision to one of the most common complaints you will ever see, the red eye. The list of possible causes is enormous, and it ranges from totally benign to, well, blinding. So having a structured framework is absolutely essential. This table right here, this is your framework. The very first question you should ask is the vision affected? If the answer is no, like you see in that top row, you're probably in the safe zone of conjunctivitis. But now look down at the bottom row. Sudden, severe pain, seeing halos around lights, and a pupil that's stuck in the middle and doesn't react, that's a massive red flag for acute angle closure glaucoma. That's a true emergency. Using these key features, pain, pupil size, vision changes, is how you quickly separate the worries from the don't worries.
And even within something as common as conjunctivitis, your history is king. Here's a clinical pearl for you. Always ask, did it start in one eye and then spread to the other? That story is classic for viral conjunctivitis, and it's your cue to be super careful with hand hygiene.
But if the patient's main complaint is an overwhelming, intense itch, you should be thinking allergic. Itching is the absolute hallmark of histamine release in an allergic reaction. All right, let's switch gears again to senses that, honestly, we often take for granted: smell and taste. It can be easy to just dismiss these complaints as a nuisance, but as we've all learned pretty dramatically in recent years, their loss can be a really important diagnostic clue. And just to be clear, this is not a small problem. Check out this staggering statistic from our source text. A full 80% of people over the age of 80 have some measurable problem with their sense of smell. I mean, that has huge implications for nutrition, for safety, like can they smell smoke or spoiled food, and just for their overall quality of life. So how does this whole thing work? Well, take a look at the diagram. Odor molecules come into the nose and travel all the way up to the very roof of the nasal cavity. Now, here's the amazing part. The fibers from these receptor cells pass directly through these tiny little holes in the bone, the cribriform plate, to connect with the olfactory bulb, which is sitting right on top. It's an incredibly direct path from the air you're breathing straight to your brain. So what can go wrong? Well, pretty much anything that blocks the air from getting to those receptors. Think nasal polyps or sinus disease. A virus like COVID-19 can come in and directly damage the receptor cells themselves. Head trauma can actually shear off those delicate nerve fibers as they pass through the bone. And this is critical. In neurodegenerative diseases like Parkinson's, the abnormal proteins can show up first in the olfactory bulb, making the loss of smell a very early clue, sometimes before any tremors start. Now for our final sensory system, hearing and balance. We're going to follow the complete journey of a sound, from a simple pressure wave floating in the air all the way to a complex electrical signal that gets interpreted by the brain. Let's just trace the path of sound on this diagram together. So it starts in the external ear, which basically acts like a funnel, guiding sound waves down to the eardrum. That vibration then gets transferred to the three tiniest bones in your body, the ossicles, which act as a mechanical amplifier. And finally, that amplified vibration reaches the snail-shaped cochlea in the inner ear. And that's the magic spot. That's the transducer, where physical force gets converted into a neural signal. So let's break that journey down into 3 simple steps. First, you've got collection. The outer ear funnels the sound in. Second, amplification. Those tiny middle ear bones act like a lever system to boost the force of the vibrations. And third, transduction. Deep inside the cochlea, specialized hair cells bend with the vibration, and that movement opens ion channels, converting it all into the electrical language of the nervous system. Collection, amplification, transduction. Got it? So when a patient tells you they have hearing loss, your very first job is to figure out where the problem is. Is it conductive, a mechanical issue like earwax blocking the canal or fluid behind the eardrum? Or is it sensory neural, a problem with the electrical parts, the cochlea or the auditory nerve? This is the most fundamental fork in the road in audiology, and figuring this out will guide your entire workup. Okay, we have covered a ton of ground from the eye to the ear to the nose, so let's pull it all together into a diagnostic toolkit, the key principles that you can apply to literally any patient with a sensory complaint. This is your toolkit. Number 1, always think anatomically. Always ask yourself, where is the lesion? Second, build your differential. Start broad, then use the history and exam to narrow it down. Third, master your physical exam. Your scopes are incredibly powerful tools for looking directly at the problem. And finally, know your red flags. You can never, ever miss an emergency that could cost a patient their sight or even more. And as we finish up, here is a little perspective from Voltaire. As we focus on all this incredible science, it's a good reminder to not forget the human element, the art of just caring for the person who is sitting right in front of us. So, we'll leave you with this final thought. You're building a fantastic framework for vision and hearing loss, but what happens when your next patient's chief complaint is just dizziness? How are you going to use your physical exam skills to confidently tell the difference between a benign inner ear problem and a life-threatening stroke in the cerebellum? Well, that's a challenge for another day. Thanks for joining us.